So I'm gonna so thank you everybody for joining us. And as people tune in, if you don't mind muting, we'll have time at the end to sort of go through and answer questions and whatnot. But it is my distinct pleasure to introduce Dr. Gabriella Ode. I've got to know her very well during the month of October when we were on our NATF traveling fellowship touring the West Coast, and got to see many of her amazing lectures. But this one was especially, I think, relevant, unique, and it goes really well with a lot of stuff that we've been talking about here in our residency. And so, really excited to allow you to get a chance to sort of both learn from her, and then at the end we will sort of open it up, and I'm sure there'll be lots of cool, interesting discussions. I don't think she needs a lot of introduction, but she is the Associate Fellowship Director at HSS. She's also one of the up and coming rising stars in the sports and shoulder world. And it's somebody I think that you're going to hear a lot about in a lot of different aspects. But surgical education is something that she's already started trailblazing early on in her career. So we're really lucky to sort of have her for this. So thank you very much for joining us, Gabby.
Thank you, Dr. Wagner. Thank you guys for having me. Yeah, so just briefly, I just want to put in a plug for how great Eric is. And I've seen some of the great stuff that you guys are doing in the upper extremity department. So, it's definitely an honor to talk with you guys today. And as you mentioned, this is a bit of a, passion project for me, both somebody who's involved in education, but also from the research standpoint. So we'll save questions to the end, but please, I'm happy to kind of stay on as long as needed to answer any questions as well. The title of my talk is Beyond the Halstead Method, so Optimizing Assessment of Residency Surgical Education. These are my only disclosures. They're not relevant to this talk, but just briefly a little bit about myself. I went to the University of Virginia for undergrad. I did my med school at Rush in Chicago, and then residency not too far from you guys in Charlotte, North Carolina, with Atrium Health and Ortho Carolina, and then came up to New York for my sports medicine fellowship, and then was in academic practice even closer to you guys in Greenville, South Carolina, just up the road, and then just transitioned back to New York, both in academic practice in Greenville and then also now at HSS. Where I'm the Associate Fellowship Director and also a team physician for our WNBA team. But, just kind of diving into the topic itself, just to lay the foundation of things. When we talk about learning, you'll see that there are 4 different stages of learning. And the first stage is unconscious competence. So that's, we don't know what we don't know. And we've all been at these stages at some point, and we're in different aspects of our life. Stage 2 is conscious incompetence, and that's where our awareness of where we are in our learning, we begin to realize just how little we know about a specific topic or a specific area. Stage 3 is what's called conscious competence. That's where we can perform a skill, but it takes attention and concentration. And that's when we can perform something consistently, but we still have to think about it. And then unconscious competence is when we actually, the skill becomes so practiced that it's actually enters our unconscious mind. It's something that we can do effortlessly without thinking about it. For example, riding a bicycle or swimming, things that at some point were difficult, but then we learn that skill. And so when we think about residency, though, the fundamental problem right now in residency education is, how do we teach surgical skills? And then also, how do we measure surgical competence? So going back to the initial foundation of this, so the Halstead model of teaching, William Halstead started the first surgical residency program in the US at Johns Hopkins. And his approach to teaching surgical education was a time-based and hierarchy-based method. So residents could be in training for an indefinite time period, and it involved graduated responsibility and autonomy, eventually progressing to solo supervision with that one skilled surgeon, and then eventually independent practice. And the phrase that I'm sure we've all heard at some point during residency training is see one, do one, teach one. And so that was from the Halstead model of teaching, where, as you gain competence, then you were allowed to do it, and then you were expected to teach what you learned. And so competency was gained through time, reps, and ultimately reading as well. But what's also kind of interesting, and there's some nuance to this, so the Halstead model of teaching is actually based on, you know, a very insidious aspect of Halstead's life. So he actually had a severe cocaine addiction, which he kicked with a functioning morphine addiction later in life. He was actually kicked out of practice at Columbia and then transitioned to practice at Hopkins. And so how that's important is that he would bow out of operations at the last minute. He would disappear for long periods of time if he needed to detox. And so his senior surgeons and senior residents actually ran his service largely without him. And so in many ways, you know, that influence on how we train, it was at, you know, at the necessity of, you know, necessity is the mother of invention. And so his addiction really did actually influence how we have learned surgery and performed surgical training for the last 100 years plus. And so the undertone of that is that the Halstead model said that more time allows for more opportunities for refinement, to polish your skill, and ultimately to accumulate some more of those stage 4 levels of competence where you know you don't know what you know. And at the tenets of that, so the Halstead model focused on direct observation in the day-to-day, multiple opportunities for assessment in the OR, in the clinical setting, with patient care. And again, those decisions to determine if a resident was competent or not competent was based on entrustability and also general autonomy granted based on where somebody was in terms of time, how much time they had put forth in service to the residency. The downsides of the Halstead model is very hierarchy based. If you were an intern, you're not allowed to do something. If you were a chief resident, you're allowed to do more, and you sort of control the service. And also, you know, competency, when it's based on an assessment by one other surgeon or an apprentice, can be difficult to measure and difficult to document because it's very experiential. And if you have an evaluator who had a certain perception of a resident, then they were vulnerable to certain biases. And so the competency-based medical education curriculum was developed in 1999, so 100 years after Halstead's method, and it shifted from process or time-based standards to competency-based standards based on these 6 tenets that we see here below. Ultimately, where the data comes from when people are making decisions based on competency is using a myriad of different assessment tools, whether if it's peer evaluations, end of rotation evaluations, global assessments, you know, in-training exams, mock oral exams, and all of that information is put forth and provided to a clinical competency committee who then assesses residents based on specific pre-assigned milestones. And so in theory, the reason there was a shift towards competency-based medical education was because competence could be then more broadly defined using, you know, myriad of information based on knowledge, skill, and attitude. It was outcome-based, not process-based. So it was allowed to focus on observed competence and not assumption based on somebody's level of training or their number of years of experience. And as a result, it could be time independent. So now we shifted away from time as a fixed metric of improvement, but also allowed for some flexibility. So in theory, if you were highly competent in your early years of training, you could complete your residency training in shorter than the requisite 5 years that we currently have. But ultimately, competency-based medical education still uses the same metrics predominantly that we saw in the Halstead method, which is direct observation and global assessments. And then there's less use of those other competency metrics that have been touted through CBME. And so here's a challenge with things like global rating scales, which we all still use right now to some degree. And so global rating scales are those metrics that you've used from when you were a medical student to residency to beyond, where there's specific categories that measure the student based on their ability instead of specific skills or tasks. So just a global assessment of how they're doing. And usually those are predominantly comparative rating scales. So residents are compared against their peers, or they're compared against a standard such as excellent, good, average, or poor. And many of these ratings are completed retrospectively and based on general impressions, so often collected at the end of a rotation where only specific bits of information sort of, pierce through to really give an overall impression. And certainly rater compliance then becomes a major issue, because as you get further away from that rotation where you have real-time opportunities to assess somebody's competence, then you're less likely to have a reliable assessment of that resident's performance. And so, are we really actually creating competent surgical residents using competency-based medical education? And this is not really clear, and it doesn't really sound like we're doing the best job. So this was a survey from almost 10 years ago. They looked at subspecialty surgical fellowship directors, and they asked them, graduates that were coming into their fellowship, how many of them thought those graduates were able to operate unsupervised for 30 minutes during a major surgical procedure? And 2/3 did not feel like their new fellows could competently operate unsupervised. And so if we go back to, the 4 stages of learning, and we think about competency-based curriculum, we realize that if we're focused just on the bare metrics to achieve competence, that ultimately means that we're stopping at stage 3, which is somebody can perform a skill, but it takes attention to detail, it takes attention and concentration. And when we think about actual mastery, so being able to perform a skill repetitively with it being effortlessly and not having to think it through, that's where mastery begins, and that's at stage 4. And we're not actually pushing for mastery when we are focused on a competency-based curriculum. Other challenges with competency-based medical education is there's less time for observation. And many of us have had this, beaten into our heads about the work hour restrictions has changed residency training over time. But, there are some concrete numbers to really, put some meat to that argument. So with the work hour restrictions, which are now 20 years in place, where residency education was limited to duty hours of 80 hours per week, that significantly decreased teaching time between attending physicians and residents. And ultimately, the amount of time in that decrease from the previous average of 100 to 110 hours to 80 hours was a difference of over 19,000 hours, or a difference of over 5,800 hours, dropping down to 19,000 hours, which is almost a year and a half of less exposure time into orthopedics and less exposure with attending physicians. So what does that do? So fewer work hours, we know that impacts the perception of resident competency and also our trust in residents. So these studies have shown that work hour restrictions are detrimental to training, because there's less perceived trustworthiness because there's less time exposed to that trainee. And ultimately, residency who logged more hours are usually scored higher on overall competency, and those who logged more OR duty hours also had higher scores on faculty evals of technical skill. And so at the crux of that is that competency ultimately depends on trust, which ultimately depends on time. So as somebody becomes more familiar with their resident and their stage in training, they're more likely to grant autonomy, which ultimately allows for more development of competency. And so if there's a lack of acquaintance, so if somebody's not spending as much time with a resident, they don't know them as well, they're less likely to give them independent responsibility, and they're also more likely to scrutinize their performance. The other issues with competency-based medical education, so end aversion bias and a fear of candor. So even with those global metrics, raters are unlikely to tell the residents that their performance was unsatisfactory or below an expected level, and they're even more unlikely to fail them. So even the global rating scales, they're not providing people who really are struggling with the performance feedback that they need to really say that they're not performing at the level they need to. This study looked at end of rotation feedback of surgical residents over 5 years, and they noted only less than 1% noted a performance deficit. However, when residents were then assessed in annual meetings like a core competency committee, that's when those deficiencies became more apparent. But typically those meetings are at the 6-month or 1-year metric before, and doesn't really allow for any improvement, because those people have been allowed to continue without improvement and good feedback over that same time period. And an important challenge that we're not addressing with competency-based medical education is also bias and equity. All of these studies, just to summarize, most of these studies who look at surgical residency, even from a gender standpoint, found that women surgical residents are afforded less autonomy than male residents, despite similar technical performance. On top of that, we do know that minority residents also consistently rated lower on their ACGME core competencies, particularly when rated by male attendings, which is very strange because it's not even a race issue. It's actually specific types of attendings. So ultimately, when we think about the flaws of all of those things, when they come down to the ultimate meeting, so the core competency committee, there are multiple flaws that the previous slides have really highlighted. So the information that we're using is retrospective. It's not specific, so there's not specific details. When you're in a group setting, you're assessing a resident, there's the risk for groupthink. If somebody chimes in and says, hey, that resident, they're wonderful, they always do a great job, and somebody doesn't quite feel comfortable raising their hand at that point and saying, you know what, I've actually had some difficulty with this resident. They're just not up to where I would expect a resident to be. It also lacks immediate transparency. So much of these are closed door meetings where the resident is not receiving the feedback that's discussed about their performance as well. And so if you think about surgical competency from an evidence-based medicine perspective, if every resident's portfolio were an individual research study, ultimately those decisions based on progression and competency would be based on level 5 evidence, retrospectively collected data, outcome measures with limited or unknown validity, considerable missing data if we're talking about people not completing the evaluations on time, and then ultimately conclusions about if someone is a good resident or a bad resident, okay resident, are supplemented with anecdotal evidence and also prone to bias. So are we then propagating a self-fulfilling prophecy? So if we talk about the Halstead method and competency-based medical education, we think about the concept see one, do one, teach one. If there's less opportunity, so fewer hours, less trust then because there's less opportunity to spend time with a faculty member, less trust leads to less autonomy, less confidence then because there's less autonomy, and ultimately with less confidence, there's less competence. And all along that cycle, there's also less quality feedback provided along the way. And ultimately, this is contributing to our residents not feeling comfortable coming out of residency and feeling that they're competent. And so in practice, time independence doesn't necessarily address the issues of trust and maturity. The assessments we use are still vague and subject to end aversion bias. Our CCC committee is still subject to potential biases. And so ultimately, when we have bad data in, we get bad data out as to how somebody is actually progressing over the course of 5 years. And in all of this, they also ignore the impact of cognitive factors and how somebody makes decisions cognitively, how it can affect their performance along the way. And so was Halstead ultimately correct? So if he believed that more time allows for more trust and that more time leads to maturation through that stages of learning at everyone's pace, and more time leads to refinement of surgical skills, if we're at the mercy of time, then even in a competency-based progression, should we just increase the quantity of surgical training? Should we go from 5 to 6 years? And ultimately, that has become a self-fulfilling prophecy in and of itself, because now 90% of orthopedic residents are pursuing fellowship. Previously, it was out of a preference to have a specific skill set, but in many ways, it seems now out of necessity to allow for somebody to really increase their competency in the areas of specific training of interest. Ultimately, I do think the answer is likely somewhere in between. We know that higher quality time ultimately can amplify the benefits of competency-based training. And so that pendulum needs to shift. So instead of focusing on time and quantity-based learning and quantity-based assessments with multiple measures that are not necessarily vetted or accurate, we really need to focus on quality-based learning and improving the quality of our reps and also improving the quality of how we assess surgical competency. And so in thinking now about how do we improve quality of learning, what we're going to talk about a little bit more is prioritizing quality reps and how we can do that, both with novel teaching methods, real-time improvement in feedback, also improving the quality of the feedback itself, and also considering the cognitive factors and non-technical skills that we haven't really focused on in the past that can ultimately affect performance. And so going now to quality reps. So think about it from the approach of multimedia. There are multiple different ways that we look at how do we increase the reps that we're no longer getting in the OR, both from work hour restrictions, but also based on the amount of autonomy that residents are not getting from previous years. And so that includes simulation training, both in the cadaver setting and arthroscopy simulation, video coaching, and then also just intraoperative reps. So simulation. So where are we now currently in the world of simulation? Multiple studies have looked at arthroscopy simulation as a way to improve performance. And ultimately what we know when we look at the smaller experimental studies is that simulation can help improve basic arthroscopic skills, particularly in novice participants, people who've never seen or touched a scope before, where they're just getting familiar with the hands and what they should be doing with holding a scope. And in many situations, it improves performance metrics, but specifically task-based metrics, such as a checklist completion or completion time. But less frequently is it going to show an improvement in quality of the performance. So, which is what measures like the asset or other global rating completions, such as quality metrics, will measure. Cadaver simulation. Is this helpful? And we know it is helpful, but it's typically best for PGY4s, so those who are beyond the novice or advanced beginner setting, but below the level of competence for, to be considered proficient for practice. And that's because cadaver training allows for opportunities for solo practice and as a dress rehearsal for real surgeries, and also allows for the learner to break through some of their barriers because there's not a time pressure, there's not a pressure from other people in the operating room to say, hey, we don't have time for this person to be working through their steps. And there's no risk to the patient as well if a mistake is made. And it allows for that person to really sort of hone some of the more specific skills in a controlled setting. But at the same time, not all simulation training is created equal. So this is a study that I did when I was a resident. We actually looked at the combination of one versus the other. Can you translate arthroscopy simulation to cadaver arthroscopy simulation? And so we did a blinded diagnostic wrist arthroscopy cadaver simulation, and residents were blinded and given a video grade based on their performance. Then they spent a month doing self-directed knee arthroscopy simulation on a simulator over a month. Then they repeated the diagnostic wrist arthroscopy skill set. So are the skills that they would learn in a simulator going to transfer to a cadaveric setting so they can really ramp up and be more effective? And ultimately what we found out is that the novices, so interns, did perform better on the repeat wrist arthroscopy after the month of knee simulations. PGY2 and PGY3 residents did slightly worse, and PGY4 and PGY5 residents did substantially worse. So what happened here? And ultimately the conclusion that I found from that study is that feedback is still crucial for quality. You can get more reps, but if there's not feedback associated with it, then it's not useful, because you're not able to get past that stage one of unconscious incompetence, where you don't know what you don't know. Ultimately, you need that feedback to be able to progress to conscious competence, where you now are aware of where your deficits are and understand, here are the areas that I need to improve. And so reps without that information just end up being non-quality reps. So what about video coaching? So here's something different. So now you're actually getting real-time performance review. Video coaching, similar to what Dr. Wagner does, where you actually have somebody going through an assessment using a GoPro, and then after 30 minutes, they then immediately afterwards went through a review with their attending, and what they found is there was significant improvement in performance. It also helped the resident feel more self-efficacious, and it achieved longer behavioral changes than just the verbal feedback alone, the opportunity to review where there are areas for improvement. And so bringing back to this figure, so what we know is if you're going to have quality-based learning and quality-based assessment, they need to interplay. So you can have multiple quality reps, but you need the quality feedback as well. So how do we improve that quality feedback? And one way is really thinking about it from a different language than good, bad, excellent, better than his or her peers, worse than his or her peers. And so we need to change how we measure competence. So instead of assigning a numeric value, the paradigm is shifting to really measure something called entrustability. And so entrustability scales are actually behaviorally anchored ordinal scales, a base progression based on somebody's level of competence. So they use judgments such as to trust or not trust, instead of translating from a scale of good, bad, terrible, excellent, or a numerical scale. And so the O score is a prime example of an entrustability scale. So using that language of trust or not trust, the levels of competence are then measured on level 1 is I had to do, meaning that the attending had to provide complete guidance. Then level 2 is I had to talk them through. Level 3 is I had to prompt them from time to time. So there's some independence, but there needs to be intermittent guidance. Level 4 is I just needed to be in the room just in case. Meaning that somebody's independent, but they still require some supervision for safe practice. And the level 5 is I trust that resident implicitly. I did not need to be there. They have complete independence and they understand the risks and are able to perform safely and they're practice ready. And so this was another study. This is where some of my interest started to grow in this area as we looked at this in our residency program. It says, can you implement a scoring system like the O score? So we looked at it from our residents and followed based on the initial studies by Wade Gofton and found that the O score does actually accurately differentiate senior and mid-level residents and junior trainees. And it is really able to pick up that advanced residents, so PGY5s had higher O scores or are more likely to be graded safely to perform procedures independently, while those who were at lower years in training, not surprisingly and expectedly, required more guidance from faculty. Most importantly, though, this use of entrustability scale avoided end diversion bias, so faculty felt more comfortable giving resident that feedback using the language of, I trusted you to perform this independently, or, as a PGY2, I would never trust a PGY2 to do that independently, but you were where I would expect you to be. And so people were okay receiving lower scores when it's based on the level in terms of entrustment. Ultimately, what we looked at, though, is it feasible? How do you implement something like this? And so our recommendations were, it has to be a tool that's concise. You have to use the entrustability language. There needs to be immediate access for the residents to review and be able to make real-time feedback as they're progressing. And that feedback needs to be frequent, at least once a week. It also needs to be flexible to select procedures that are maybe outside of the ACGME milestones. Ultimately, if this looks familiar to you, it's because for many people, this is what ABOS has recently implemented in the last few years. They took a combination of the O score and the P score, which is a single summative rating that just says, how is this person doing? And they created the ABOS OP surgical skills assessment tools, which really focused on core procedures. And their recommendation was to implement this twice weekly. So, now if we're talking about entrustability language, can we also create higher quality reps in the real-time setting? So moving away from simulation training and really focusing on how do we then break down specific reps and make them higher quality. And this is where entrustable professional activities may have a burgeoning role. So EPAs, so that is when you actually break down specific tasks or a responsibility into a measurable framework or building blocks of aspects of training in daily practice. So they have to be independently executable, observable, and also measurable. And so in order to work through an EPA, there has to be observed proficiency, usually on multiple occasions, to determine if somebody can be entrusted to perform a specific task. So here's an example for teachers and attendings to really break down a task into an EPA. So for an example, here's arthroscopic cuff repair. You're walking a junior resident through it. So break down each step. So this is typically how I will assess a resident or fellow with me and determine if they're competent to move to the next step. So breaking it down to prep, position, and drape, the diagnostic scope, biceps management, moving into the subacromial space, specific aspects of that, cuff preparation, anchor placement, suture management, and knot tying. And it doesn't necessarily mean that there's a progression in this from that this is the minimum and this is the maximum. So you can pick and choose specific areas that you want to focus on and really demonstrate that somebody's competent to perform this independently. Here's another example. So for if I have a fellow with me and we're talking about doing a reverse shoulder replacement, so again, prep and drape, delta pectoral approach, how I would do it, what to do on the humeral side, focusing now on the glenoid side management. I do computer navigation, which is its own kind of unique skill set that requires its own independent practice. And then trialing and understanding what that feels like to trial and demonstrate what's too loose, what's too tight, subscapularis management, and then closure. And you can really break this down into independent steps to determine trustability. And so for me, this has been helpful as somebody that's still early in practice and still very handsy, understandably. Time is money. Spending more time in the OR is time that dictates what I'm allowed to do, and ultimately my OR time moving forward. So I can't necessarily sit back and leave the room and have somebody work through their learning if I'm trying to get through my cases. So I use this as a way to say, okay, see one, do one, and then I want you to see one again, or pick 2 of the 3 aspects, or 2 or 3 or 4 of the EPAs that we talked about, and you tell me what we want to work on today. So then I can, speed through the other things that I know I can move quickly, and we can focus on this aspect of your learning right now. And ultimately now that allows us to really focus, or allows a resident to really focus on how am I going to improve my performance. And so the next area we really want to think about is how do cognitive factors interplay with surgical performance, where we've moved past, the technical aspects of thing. And this remains that kind of black box where we don't really still understand how do we have somebody perform at the same level and improve with the same attending or in the same case. What are the barriers that can affect their performance cognitively? And this is an area of interest to me. So looking at psychometric assessments, and psychometric assessments, that includes assessments of personality, learning preference, leadership traits, stress and burnout, and how does that affect our decision-making and performance. This is a study group that we are in year 3 on, and that I started while I was in Greenville and Prisma Health, and we're still working through a 5-year longitudinal research group. We have 11 programs, 183 residents, about 78 faculty right now. The goal of the study group is to really evaluate cognitive processes over the length of surgical training. How do we go from a medical student to an independent surgeon, and how does this affect our performance across the spectrum of professional development? So some of the studies we're looking at is really even looking at how do orthopedic residents prefer to learn. So this is a study that we looked at where we looked at the VARC, which looks at learning style and preferences. And so people could either fall into a visual preference in how they learn, auditory, reading, writing, and kinesthetic. It's a 16-question survey that allows people to really say, hey, this is how I prefer to digest information. What we found is that most orthopedic residents are kinesthetic learners. So kinesthetic, part of that is, hands, touch, but it's also experiential learning. The opportunity to see and do something on their own, and then be able to say, I'm going to be able to execute that because I had that experience. And certainly that makes sense, right? We all enjoy being in the OR and getting those opportunities and reps, but we took it a step further and we asked people specific examples of orthopedic learning media for how they prepared for a surgical case. And what we found is that despite the fact that the majority of orthopedic residents are kinesthetic learners, this ends up being, for an example, if you looked at kinesthetic media, such as templating, cadaveric training, simulation training. So what we talked about before, what we found is that this ended up being some of the least utilized learning media for surgical residents. These areas fell low compared to other metrics that people are using for surgical training. So even though residents can indicate a preference, we're not necessarily offering the opportunities for them to use those preferences, or out of necessity, they don't have access to those preferences to really kind of maximize their learning potential. And so there's more to come based on posts, which those are some of our initial studies from that standpoint. Another area that, is something that we're really getting a better understanding of is stereotype threat. So what are the cognitive barriers to performance? So just briefly, stereotype threat, it's a unique psychological phenomenon where if there's a perceived fear of fulfilling a negative stereotype about one's identity, that can potentially lead to impaired performance. And the most common studies will look at aspects of negative stereotyping based on race or gender, and how that can ultimately affect somebody's performance. And so for an example, this study looked at how gender bias and stereotypes in surgical training potentially could affect surgical performance amongst female trainees. And so in the study, residents were reminded of negative women's stereotypes in surgery. Specifically, they were given an abstract that indicated that women are worse surgeons. The residents who received that abstract, the women who had higher vulnerability to stereotypes, or a higher perceived perception that women had lower performance, they had worse surgical performances. Men who had higher stereotype vulnerability, so who were more sensitive to the perception that their gender affected their performance, actually had better performance when they read a metric that said that women were worse surgeons. So this is actually termed stereotype lift, where the perception of somebody else who's not of your stereotype is doing worse allows you to feel like you can perform better. In fact, when they removed the negative women's stereotypes, so now reading a passage that says men and women do equally well at surgical skills assessments. In this setting, when the stereotype was removed, women performed better, and the men with high stereotype vulnerability actually performed worse. Ultimately, we have only just started looking at this in orthopedics. This is a paper we're going to be submitting to core soon. We actually measured stereotype vulnerability by race and gender at over 300 residents at 40 programs. And what we found, we had a relatively normal balance in terms of minorities and or women, so about 25%. So actually a little bit overrepresented compared to the current orthopedic population in residency. But we found that there is high stereotype vulnerability based on race. So specifically, there's higher stereotype vulnerability amongst orthopedic residents who indicated that they're Hispanic, Black, or Asian, compared to white orthopedic residents who had a baseline score of 9, which is actually the lowest score you could get based on the metrics. And note that 15 points is considered high threat. So many did not quite meet that threshold, but they were certainly higher. And what we did know is that Black residents and non-diverse residency programs, they did actually meet that high threat measure. So they had the highest overall race stereotype threat vulnerability, a score of 16, compared to Black residents who were at more racially diverse residency programs. While white residents who were at a non-minority program, so in the programs that were predominantly white, again, had the lowest vulnerability based on their race. Gender, so again, high threat, 15 points. Women at non-gender diverse programs, so women in the programs that were predominantly male had the highest stereotype gender threat, so a score of almost 18. Now, if you put them at programs that had some gender diversity, slightly lower, but still high threat, so still above that 15-point threshold, while men at non-gender diverse residency had the lowest threat in general. So this is certainly an area we still don't know how does that affect performance, but we know it's an issue. And it's certainly an area that we need to consider if we're talking about surgical performance in general. So some recommendations on how to mitigate stereotype threat and performance is introduce the concept to your department, which allows both faculty members as well as residents to understand that this could be something that could potentially affect performance. What we do know is that ends up actually reducing the stereotype threat if people understand, hey, that could be what's affecting my performance. And it also allows to allow for the opportunity to really provide safety in the workplace culture. So understanding how do we reduce stereotype vulnerabilities, so having high representation, understanding the value of diversity, and also demonstrating that we understand which cues can indicate stereotype identity threat. Other ways to mitigate that threat is recognizing situations of high visibility performance can potentially exacerbate stereotype threats. So what are examples of this? So when you're putting somebody in a performance setting where they may feel like, hey, I'm afraid I'm going to choke, conference presentations, their in-training exam, the operating room where they have to perform in front of their attending, and then even post-call checkout where you're presenting how you treated a patient overnight. But also don't avoid constructive criticism if somebody is not doing well. So the goal is to provide feedback, again, quality feedback that is free of bias, that does not potentially invoke those negative stereotype threats, negative stereotypes, which can ultimately affect performance. And one way that I'd recommend this, that's actually been shown in different studies, is stereotype feedback that's least likely to trigger a stereotype threat is communicating high performance standards, but also reassuring the individual that they're capable of meeting those standards. So for example, if somebody's not performing, did they not perform well in the OR, or they made a mistake, instead of saying, gosh, you did terrible in that, instead of say, I know you can do better than this. And that conveys the high standards that you have for them without them feeling like this is a result of a negative stereotype that they are emanating. So going back to our stages of learning, so we've talked a little bit about reps and feedback. And so we know that quality reps and feedback can help us get to that stage 3 of competence. And if we're talking about competency-based education, that's where that metric is. How do we get to stage 3? But how do we get beyond stage 3? Is that realistic? Can we get residents achieve mastery? And is that really realistic in a 5-year training program? And this is where there's a role for specific learning that enhances what are called non-technical skills and really measures and hones cognitive performance. So non-technical skills. So this was actually developed in 2006 by the Royal College of Surgeons in Edinburgh. They actually provide several master classes that really talk about behavior in the OR and cognitive processes when we're making decisions. And it falls into 4 categories. So situational awareness, decision-making, communication and teamwork, and then ultimately leadership. And part of the argument for the use of non-technical skills is this quote, which I love, which says, being a good surgeon is more than just being a good pair of hands. It's about being a good team player, somebody who listens and communicates with patients and colleagues and empowers them to reach their full potential. And so they actually have a specific rating scale called the KNOTS, which really, the one caveat is it uses, the ratings that I don't really like, which is good, acceptable, marginal, or poor, not in trustability language, but it really allows for people to assess, is somebody able to utilize situational awareness and leadership in specific tasks in the OR? And not all elements may be required at a given encounter, but it really allows us to start thinking about it from language other than just the hands and technical performance, but actually the decision-making process that really delineates who makes a good surgeon, who makes an excellent surgeon. And so going back to that fundamental problem that we're talking about, so residency training has changed. We know this with the work hours, we know this with the model of training, but ultimately we need to know what vehicles will allow us to improve surgical skills acquisition and also how we improve competency. And so some from future directions that I think we need to highlight is the benefits of competency-based training. We don't want to throw the baby out in the bathwater, but we need to focus on the assessment metrics and using diverse assessments and actually using them to a level of higher quality. That includes higher quality teaching and also higher quality feedback. And that can be done through use of EPAs to provide graduated responsibility. And also remember that, outside low fidelity training like simulation, it's helpful, it has a role, but there needs to be some guidance in order for it to really be more high yield. And ultimately, that's where I would encourage use of early and frequent feedback, such as using the O score if we're talking about surgical performance in real time, as well as the NOTS, which is the non-technical skills assessment. It really talks about how do we improve performance and decision making, and also recognize that the impact of bias and stereotype threat in surgical training is real. These are real issues that can ultimately affect performance of a trainee and those moving forward. When we were at one of our sites for NATF, this stuck out to me because one of the residents asked me a question and asked, is this talk primarily for residents as learners or surgeons as teachers? And I would say it's both. There's much that we can learn about how do we optimize our own performance, but ultimately how we as surgeons, when everyone is moving forward and really teaching somebody behind us, how can we be better teachers? And that's where the conversation really needs a shift. And so I would say I would make this last point, which is, as teachers in particular, we need to be more transformational and not transactional. So the difference between transactional leadership is providing contingent rewards and really motivating using reward and punishment, focusing on short-term goals, promotions as a way to tell somebody that they're doing well, while transformational leadership really focuses on the commitment to learning and providing somebody tools for long-term success. And that involves understanding that we have to have patience with our learners. There has to be tolerance for our resident presidents in the OR. And tolerance is not the same as quality teaching. Just because somebody's there and watching you doesn't mean that they're getting the most they could be getting out of that experience. Your resident is more than the service that they provide. And so ultimately, we need to be using benchmarks that allow for meeting those competencies, but also encouraging continued development of stage 4 competencies beyond the spectrum of learning in 5 years. And so that's all I have. Thank you all. I'll take any questions people might have, and I'll probably let me close out my window and we can stop the share from there.
Amazing. Well, thank you very much. Before I prep you with one, since I've heard this or heard variations of this, although I don't know if I've heard the whole thing, so that was awesome. I'm going to open up for any of my colleagues. Please engage Dr. Ode. That talk was phenomenal, absolutely phenomenal. I've actually gotten tons of texts already about how good that was. So thank you for giving that to us. But does anybody have questions for Dr. Ode?
Hey, that was a great talk. Thanks so much for being here with us and giving it. I'm Paul Grieve. I'm one of the plastic surgery hand surgeons here in the upper extremity division. I just had a question about, what it's been like for you to sort of, promote change within education. And have you, run into any challenges with that, either convincing colleagues to kind of buy into new methods of education and kind of doing things differently as opposed to the way they've always done it? Or if you had pushback from learners who are kind of used to kind of doing it the same way that previous generations have done it. Have you encountered that, and how do you sort of address that situation?
Yeah, I think I think culturally there's an idea that as surgeons we're good teachers, right? Just inherently, and that's an absolute fallacy.
I think we're terrible teachers. We can't even agree on how to teach.
Exactly. We can't even agree on how to teach. And so I do think one element of sort of dangerous teaching is the thought process that I treat everyone the same. I teach everyone the same way. And it encourages people to bend to your learning and communication style, not realizing that some people learn differently, very differently. And I think that remains a challenge, because many people will say, I've taught people this way for the last 30 years. And, that doesn't mean that that's worked for everybody over the last 30 years. And it creates a self-fulfilling prophecy, because then somebody who learns a certain way that meshes with that person's teaching style, that's a good resident, right? They're great. They know how to do exactly that. And then the resident who maybe has a different style, maybe they're an auditory learner, or maybe they need more one-on-one discussion as to what the case is, or they want to feel comfortable asking questions and it's not the right time in the OR, that person then falls behind. And the teacher then says, well, they're not engaged, or they're not doing it the way I need to, they're not good. When it's really, this just hasn't been the way that they needed to learn. And so I think the challenge right now is having people understand that just because it's worked for you doesn't mean it's going to work for somebody else. And how do we then get buy-in from our surgeons to really say, okay, I'm excellent, right? We know many master surgeons who are terrible teachers because they are level 4 learners. You know, they don't know why they know something anymore. They can't remember the steps that got them there. Like, how do you talk somebody through tying their shoes? How do you get somebody on a bicycle? You're like, I've been doing that so long, I don't even remember how to discuss that with somebody. And so then it becomes a process for us as teachers to really say, where am I not being effective in how this resident learns? On the other side of the coin, I will say that sometimes residents also need to be more flexible with their learning style. So instead of being, I don't like how that person teaches, I'm going to shut down, or I'm just not engaged, to say, okay, well, where am I having a challenge with this, and how can I adapt? Because this isn't medical school anymore. You may not have time to read the entire book. You may need to now take an opportunity to be flexible about how you learn that case. You may only have learned about the case that morning, but you still need to be prepared. And it's not going to be the way that you used to prepare for a case. So how can you now be flexible in how you've learned before in order to adapt? And so I see it both ways, where, you know, people can be rigid in how they learn, but people can also be rigid in how they teach. And that remains kind of a fundamental challenge to say, if we better understand that it's not the same for this person and that person, then that gives us an opportunity to really say, how do we develop curriculum that may work for this person or may work for this person? And that is actually one of the areas in post that we really want to look into is, okay, what do people use? What's the predominant, you know, there are going to be generational differences too, as well. What are our current residents using to prepare for cases, prepare for their in-training, and how is that different from faculty who may have learned or be doing continuing medical education a different way than our residents may be doing?
Great, thank you.
So when I first started operating with residents, I was in private practice for a couple of years. And so I had to kind of like think about, okay, how do I teach and how do I want to teach and what did I like and what I not like? So now I try to kind of like sit back the first couple of cases and figure out, how does the resident want to learn? Do you have any tips or tricks for that? Because I could use them.
Yeah, I would tell you better than me. I never sit back on the first couple cases with the resident. And that's just because I'm a control freak. And
I didn't even sit back with my hands.
Yeah, so I tell residents, because I think it's important for a resident or fellow to know your threshold with what you're going to allow. Because many times they can internalize, they're not letting me do something. Is it because they don't think I'm competent? Is it because it's me? And so I tell people up front, I don't let anyone do anything the first time. I'm going to talk you through everything I'm doing because I want you to see it. And then the next case, we're going to talk about what I'm going to allow you to do. Because I think it's also unfair often for people to assume that the resident knows exactly how they do something. You know, you may, you know, for me in shoulder arthroscopy, how I make a portal incision is probably different than one of my partners. And so if I'm going to hand a resident a knife and say, all right, make an incision, and then they're going to make a horizontal incision, I'm just like, whoa, I don't do that. But I never told them that that's how I do it. So how are they going to kind of build up that information? So me personally, I like telling them at the start of the case, hey, this is my first day working with you. I'm gonna do this part. Where do you feel comfortable? Where do you want to work on? What have you done a number of times? And yeah, I'll let you do that part, but I also want you to see how I do things. And then if we have the next case, then I'm going to let you fly for this portion of things. And then if that person has demonstrated some competency in that aspect of the case, then I say, okay, this next case, you're going to do this, you're going to do this next step as well. Or I'll ask them, how many subacromial decompressions have you done, or how many humeral sided preparations, how many delta prec approaches have you done? Okay, you feel confident doing it, then I'm going to blow through that because I know that I can catch up on time, and I want you to focus on the glenoid, right? If we're talking about arthroplasty. And so then I, as a surgeon, can catch up on time, but still allocate a certain amount of time for them to learn this particular case or this particular part of the case. And then we can kind of move at a pace where then the next case, it's like, all right, you did that last case. Do you want to do that again and work through some of the kinks, or do you want to do this part now? And so give some autonomy for people. Like, I've done a bunch of delta pec approaches. What I haven't been allowed to do is the glenoid side, or I haven't been allowed to do the humeral side, and I haven't been allowed to reduce the shoulder. I want to know what that feels like. So it allows for some flexibility for them to really kind of pick and choose the areas where they feel that there are deficits. Does that help? I don't know if that's.
Yeah, no.
right.
And then I have another question.
Mhm.
So when you're teaching a resident, do you make them do things exactly like you would do them? Or do you kind of like watch and look, just like a portal, say, okay, well, I normally make a vertical, but I'll allow that, keep going. What is your duty to them? Do you want them to do exactly like you do so they can pick and choose? Or do you let them kind of figure it out? And maybe it's not exactly how you would do it, but it's probably going to be okay.
Mhm.
And then
Yeah.
you can probably get them out of it if they can't.
Yeah, I think I'm lucky from the standpoint, for example, at HSS, so our Sports Medicine Institute, we have over 30 sports docs.
Yeah.
And so when I was a fellow here, each of our blocks, we worked with a bunch of different people. And so we had to learn everyone's different way and how they do things. And so I think that has helped me as the associate fellowship director. So when someone's in a case with me, I'll say, this is how I do it. I know so-and-so does it differently, or they haven't even been on that rotation with that person. I'll say, hey, so-and-so, just so you know, this is how they do it. This is how I do it. Do I let them do I let them do some things differently, but probably rarely. I don't dictate to people how they should tie their knots if they can tie a good knot. So that's a prime example, right? In arthroscopy, I ask them, what do you do? Are you doing, alternating half hitches? Are you doing, a different kind of knot? Like, okay, well, let me see you do this knot. And if that's how you feel comfortable, I'm not going to make you bend to how I want my knots tied if this is how you prefer to do it. But other things, how they close, I'm not going to dictate some of those things, but I still want them to learn how I'm doing things while allowing them the opportunity to hear how that this is not uniform. So I'll say, hey, you're going to see somebody do this differently. This is not how you do it in every case. This is just how I do it. And I'll let them know where there's some nuance in that. So they know it's not, this is how you do it every time in every case with every patient. These are where some of it is just nuance of the surgeon.
Hey, Gabrielle, it's Spiro Karas here. How are you?
I'm good. How are you?
Very much enjoyed your talk. Let me, if you've got a second, I want to get a little more granular with you as a fellowship program director myself. We're constantly challenged by the metrics by which we judge our fellows and of course our residents. So obviously a lot of detail in your talk, a lot of different metrics. What are you guys? So for instance, we're using milestones, a 360-degree evaluation, direct feedback, in terms of our metrics. What are the metrics that you feel for those PGY6s, do you feel are most effective for you guys up in New York to do assessments of your fellows? What hardcore metrics are you guys using?
So this is an evolving, so this is an area of evolution right now. So, and actually today I was working on building my O score for our residents, because we're going to have our fellows, our mid-year feedback in the next month. And I encourage the faculty to provide feedback to the fellows directly, but also there are checkpoints that we have and say, how is somebody doing? And if somebody tells me, they're not great, then I call them and I ask, but what does that actually mean? I need granular information as to where this person is having issues. Where can we sort of intervene? And now we're getting close to kind of about the 40% mark with the fellowship. So my plan is to have each of our core faculty fill out an O score for each of our fellows separately. So the key thing is, and this has been an area where there's been some discussion, because everyone's natural tendency is like, no, we got to get together as a group and talk about each of the fellows. We need to do that in month 1 or month 2. And I have pushed back on that for a few reasons. One, because of the issue of groupthink, which is that person has only worked with a couple people. And maybe they're struggling on that rotation. Maybe their style does not mesh with that person. And what I don't want is in a big room with tons of faculty for one person to say, this fellow is struggling. And then they go to the next rotation and they've got this monkey on their back where everyone said, well, we heard that fellow is struggling. Now they're thinking about it all the time, or they're not getting the opportunity to say, you know, in this rotation, I'm doing pretty well. So I want the metrics blindly, let people fill out their O scores and say, this is how they're doing on our core ACGME competencies. And then we're going to come together and actually sort of look and say, okay, so are there some outliers here? Is this something that this person just improved, or are you seeing a certain struggle? The other thing that we implemented this year is I sent all the fellows a pre-fellowship survey with each of the ACGME competencies. So ACL, meniscus repair, knee scope, etc. And I asked them 2 specific questions for each of those metrics. I had them fill it out. I said, approximately how many of these did you do in residency? And how comfortable do you feel doing this procedure? And then I distributed it to our faculty once we kind of, teased it out. Because what we know is everyone's residency is very different. And so you can have a fellow who's done 100 open shoulder procedures, but didn't get a lot of arthroscopy, right? Or they did a ton of knee and they did very little shoulder. They shouldn't necessarily be compared to the other fellow who did the exact opposite. Their skill sets are different. And I think having that information up front to say, okay, this person's coming in with no experience here. We got to start kind of from the ground up and kind of build their skill set, as opposed to the person who says, I've done a ton of these, or they've done a ton of them, but they weren't actually allowed to do anything, right? So the person who's done 50 rotator cuffs and all they did was hold the scope, and they still don't feel comfortable with this, all of the steps. So the second question is just as important, not just how many did you do, but how comfortable do you feel with that procedure, and where are you starting, so we know where we can kind of get you, how we can get everybody to the same level by the end of the year.
Good. Good. Thanks.
Amazing. We're around time. Anybody else have a question that they want to engage Dr. Ode with?
Dr. Ode, I'd like to ask a question. Zamin Hussain, PGY3 resident at Emory. Thank you so much for your time this evening. I just wanted to do a quick deep dive into reaching stage 4 on the mastery side of things, because I know you kind of mentioned that whether that was realistic or not. And often I feel like that stage is probably when you're in the room by yourself, kind of doing the more challenging parts of the procedure, the more risky parts of the procedure. I just wanted to know, how do you reconcile that with providing the best patient outcomes, kind of letting a resident do that stage, and potentially upholding your reputation if that part of the procedure is not performed optimally or exactly how you would like it. And obviously, ultimately, you're taking responsibility for the case. But then how do you reconcile that with the resident only being on your service for, you know, a short period of time? And I guess that also applies to the fellow as well. Yeah, I'd like to hear your thoughts on that.
Yeah, I mean, that's the black box question, right? I don't know the right answer to that, because it's going to be different for every case and by every procedure. They're going to be more straightforward cases, whether if it's a certain, like a knee scope, or, you know, the subacromial decompression on a cuff, where you, as a surgeon, you understand, okay, the mistakes here that can be made here are minor and correctable, right? As opposed to other parts of the case where you, as the person who's the lead in the room, so the attending, part of the mastery is understanding where the problems could be, right? Like, how could somebody else screw this up? Or how can I screw this up? That's part of the situational awareness, right? And understanding, okay, can I correct a problem when it occurs? And how much of that risk could potentially affect the patient outcome. So, you know, minor things can occur in a case that you could say, you know what, in the grand scheme of thing, if you make a mistake here, it is very correctable. But other things may require, and I'll tell a resident or fellow sometime, hey, I'm just letting you know, I never let the fellow do this part. And it's not because I don't trust you, it is because I don't trust you. But it's also because I know if something bad happens here, I need to own this fully, and it needs to be my mistake. So, and they'll see it, right? We've been in cases when you're a fellow, or when you're a fellow, you'll be in cases where something happens in the OR or an attending makes a mistake. You learn so much from seeing how they work through that step, and you still retain that information. Some of the most memorable cases that I've been in is where something, I'd never seen that before. Oh, wow, they broke that. Whoa. Like, you don't want to be the person who did that, but you'll always remember that, and you'll always now have that in the back of your mind of what could go wrong here. I had that experience of seeing somebody else walk through it. And then when you're in that situation, when it does happen, you're still able to kind of build and move forward without necessarily having to be the one that made that mistake in that time. And I don't know if that's right. I really don't know if that's right, but I will say, you know, when I'm thinking about certain cases, and I've said, you can fracture the humerus here, I've seen this. Doesn't mean that I've done it, but in my head, I've experienced it. And so I know how to be prepared to avoid that. So you can still learn that way, even if there are parts of the case that are very challenging and difficult. And I don't know if any of the other attendings on here will agree or have been, you know, experienced that or seen that and some of the nuance of that. Eric?
Yeah. I mean, that is, yeah, it is hard. It is really hard because you're balancing, obviously, a really important part of your job is education, but also with certain aspects of patient safety. And then you're also balancing different learning levels between, you know, residents and fellows, and that whole works and what they truly are capable and whatnot. And actually, that for me is one of the hard parts is trying to quickly determine like what is safe at different levels and what's not.
Yeah.
When you're working with many different learners at many different levels, and then and sort of paying attention to that, and you know, people like residents like Z, who's very competent but also not going to tell me, hey, like, by the way, like, I'm not exactly comfortable with this, because he wants to like take advantage of any opportunity he can. That's hard. That's hard to then like interpret like what they truly are comfortable with, what they aren't. So I admit that's been without question one of the biggest learning curves I've had early on in trying to figure out all that out. And I think it's something that's that is tricky and kind of I don't know. I mean, you said on the head. It's one of those things. I think you have to do graduate time. But the problem is, like, as probably with you all, like, you know, the residents are with us for like a month, right? Or the fellows are with us for like a month. So it's not like you're with them for 3 months or 6 months, and you can have this like long process. So it's a little, it's challenging for sure.
Yeah, I do my best to try and talk through a lot of the cases, even the parts where I'm like, all right, I'm going to take things back and do this part of the case. Is I kind of talk through the steps throughout the case. So I'm still moving. One, it's also good practice for me, I think, to be able to sort of, it's like walking while you're talking, right? So, which at some point in our life we weren't able to do, but helps us even as surgeons to say, I'm talking through while I'm doing this aspect. So it's practice for me as well. But it also allows me to kind of walk people through some of the pitfalls, you know, and say, hey, you know, with this step, you know, say for like, you know, an anatomic total shoulder, like, hey, you have to be mindful, you could cut the cuff here. And that absolutely changes the entire course of the case, and talk through, hey, here's how I avoid that. You know, here's what you got to be careful of. And then I've talked them through that, and then allow them the opportunity to do it if I trust them enough and they've demonstrated that they have, you know, the hand-eye coordination to do that step safely. I think of a prime example of a case, you know, I had a PGY2, we were just doing a reverse, and I was like, all right, well, you know, just, you know, I just want you to, you know, hit the poly onto the, you know, on the humeral side. And he had been on joints before. And so he goes, bam, like as hard as possible, and cracks the calcar. And I'm like,
Damn.
okay, I didn't tell you explicitly that this is not a step for brute force, right? So that's on me. So what I learned from that is now that's like probably one of the simplest parts of the case, right? So that's why I was like, oh, you PGY2, yeah, you just pop it on, it's fine. And I was like, now I know that I need to articulate to everybody that this is a light touch, right? This is a light touch. This is not hammering on the poly with full force, because you can harm that patient as a result. So those little things tell me, okay, well, I'm not going to, that doesn't mean I'm not going to not let the next resident do that, right? But I need to know, okay, where can I guide somebody through the potential pitfalls in this part of the case, so I can trust the next person to continue to do it. And that's just a learning process too. And we all know great teachers who have seen every mistake in the book, and they know how to make every correction. So they feel comfortable walking out of the room and saying, all right, if you screw something up, like, I can fix it. And that's also kind of our process of learning what we feel comfortable addressing and fixing, and what our threshold is to sort of guide somebody. And that's where me, as even a still kind of young attending, I'm still, you know, growing and deciding what I'm willing to allow those risks. When it's true, my reputation is on the line if a major mistake is made. So.
Very cool. All right, one last thing. So, you know, Gabby, one of the biggest things, and we've had this conversation, but I just wanted to let everybody else hear your thoughts. You know, one of the striking things about the presentation, a couple of things. One, the story of Halstead I love. Two, your study on the residents actually regressing by not actually participating in active learning, like by doing arthroscopy but not getting feedback, and then they actually like don't good. So the idea of just going and doing lots of cases without actually critically analyzing yourself or getting feedback about it naturally is something that sort of maybe was okay back then, but doesn't seem to be the way to go. So, you know, we've talked about what the future of education is, you know, from you know, incorporating technology to incorporate different ways of learning, to trying to inspire others, colleagues, to participate more actively despite their limitations in time. So 10 years from now, what is the biggest difference, do you think, that maybe at HSS or maybe here at Emory that we are going to be doing that we're not doing now?
I think we're going to do it better. We're going to probably start using augmented reality more to provide higher quality reps. and that involves, you know, being able to walk somebody through as if they are through your eyes and doing the same task, whether if they're scrubbed in or if they're watching you do things. And that technology is evolving and growing, but it allows people to really see it from the perspective of how you're making decisions. And I also do think that there is some aspect of measuring certain metrics that I think will help with performance. So part of the reason why the virtual simulators probably aren't very effective in isolation is because there's almost a critical focus on metrics such as like time, tasks that you're completing, without somebody, you know, saying, hey, your hands, you should be holding the scope this way, or you know, your hands should be this way. So the combination of those two things is going to be critical. So having an opportunity for somebody to see and guide somebody real time through a simulation, you know, and have better haptic feedback to say, no, that's not where your hand should be. And also providing real time feedback on things like time, what steps were you getting bogged down on, you know, like where is it time sync? I love, you know, during one of your talks, Eric, when you were talking about tendon transfers, where you talk exactly about what you've learned using the GoPro, watching back and saying, why was I inefficient in this step right now? And then being like, whoa, that's crazy. I wasn't progressing. So what can I do differently to progress in that step? And so being able to watch that in real time, have the metrics to say, you know, during this step, it took you this long. What held you up? Was it, you know, something that was out of your control? Or was it a step that you need to personally be more efficient at? And I think that's where we're going to be using metrics and even machine learning to say, hey, this is how we can be more efficient in these steps. What are things that we can eliminate, you know, time and inefficiencies.
Fantastic. That's awesome. Well, thank you very much. Thank you for also going over the time. As you can see, was fascinating. And per Adrian's influence, I already posted on social media about it, so you'll be seeing that tag. But yeah, thank you very much for spending time with us. Maybe I would love one of these days actually bring you down in person. So hopefully we'll be able to do that, and you can meet a lot of my colleagues on this call and many others. And yeah, it was really awesome talk.
Yeah, thank you guys for having me. Yeah, it's 37 degrees up here in New York, so I do miss the southern weather, in particular on days like this. So, and be happy to come down for an in-person at any point, just to stay warm for a little bit.
Get some good soul food. Get some good
Yeah.
All right. Thank you, Gabby. We'll be seeing you soon. Have a good holidays, and thank you everybody for tuning in.
Yeah, thank you guys. Happy holidays.